Good afternoon, and it is really amazing to see what an awesome audience all of you are, really. I've gone through several lectures in my life, which is quite a long time, but I've never seen such a committed audience. Hats off to you. I think we should give each other a big clap. That was a weak one. All right. Thank you, Dr. Jayakrishna. You've really done an awesome job, but not given me such a nice lecture. The endometrium is one of the most fascinating tissues of the human body, and its only purpose is implantation of the embryo during that short window of opportunity when it can implant. Successful implantation requires a two-way interaction between a receptive endometrium, a functional embryo which has reached the blastocyst stage, and a synchronized dialogue between the maternal and the embryonic tissues. And if we know that one day we were all like this, we did a real good job. We now know from data that the contribution of the uterus for a pregnancy is about 31 to 64, and an inadequate endometrium could be one of the main fertility determining factors. So I think it is so important to know about the endometrium, and particularly a thin endometrium. And the topic given to me was a thin endometrium. Do we have a solution for it? What is the evidence? There are certain concerns, and these are: what constitutes a thin endometrium? Can it be the cause for the problem of fertility in that particular patient? Does this mean that a thick endometrium is not correct? Which tools are best for determining the endometrial thickness? What are the causative factors? What are the strategies of management? And what next if nothing works? So to approach this, most of our patients who come say, "Doctor, do something for us." What's the evidence? So let's look at the agenda that I wanted to use for this particular lecture. First, we'll define the problem. Second, the frequency, discuss its impact on pregnancy rates, discuss the possible etiologies, find out the methods we can assess the endometrium, and then the solutions. And for this, I have 16 minutes and 20 seconds. Nature took 9 months. So when you look at what is a thin endometrium and you look into data, you have anything ranging from 5 millimeters to 10 millimeters, but most of the evidence now says an endometrium less than 7 millimeters is considered a poor endometrium, or a thin endometrium. The next question is, when do you measure it to call it a thin endometrium? And that's on the day of HCG. There are controversies. Like anything in life, be it marriage or the endometrium, there are controversies. Do you call an endometrium a thin endometrium based on its thickness, at its point of maximal thickness, or would you look at the volume of the endometrium and say a volume less than 2 ml means the endometrium is a thin endometrium? And volume now is measured by 3D, and we can do it pretty easily. So let's see what happens in a thin endometrium and why is it that it has a problem. A thin endometrium comes because there is a resistance to the blood flow, particularly in the radial vessels. This results in poor vascular development, and because of this, you have glandular epithelium not getting proliferated, and there's less vascularity, and hence you have a thin endometrium. This could be the reasons why an endometrium is thin. So when you look at data again, and you look at the growth of the glandular epithelium in patients with the normal endometrium, it's good, while in a thin endometrium, you can see it consistently lower. When you look at the radial artery resistance index, it is much higher in thin endometrium. When you look at VEGF expression, again in thin endometrium, there's hardly any VEGF expression, and you can see it consistently lower. So understanding that there is a problem with the vascularity and the glandular components, you have now methodologies in the management strategies. Let's now see the frequency of the problem. It can be anywhere between 3 and 9%. What is its impact on the pregnancy rate? We know very clearly from data that any endometrium less than 7 carries a low pregnancy rate and a low live birth rate as well. The etiologies, it could be congenital or acquired. Let's go in terms of the most common in our country. One is tuberculosis. Second is Asherman syndrome following repeated uterine injuries by surgical procedures. It could be the use of clomiphene citrate, and of course the androgenic environment created in a PCO patient, like the one Dr. Jayakrishnan was talking about. And of course, in congenital, you could have a very poor endometrium in patients with Turner syndrome and hypogonadotropic hypogonadism and Kallmann syndrome as well. And also, when you see a consistently thin endometrium, always do a 3D, because you might be dealing with a T-shaped uterus or a unicornate uterus. These are the uteri that respond very badly to stimulation during the ovulation induction. The next is, what are the methods? The conventional methods, of course, are looking at the thickness and the texture. The newer methods that we can use is endometrial volume. We do it all the time. We look at endometrial vascularity, particularly the subendometrial blood flow. We also quantify it by histograms. And of course, you have the ERA, which is an assay. How effective it is another question, but it is extremely expensive. Sonohystrography and hysteroscopy should be done in all patients who have a recurrently thin endometrium, because you can actually find out the possible causes in that particular patient. So coming to the main part of the talk, what are the treatments that are available? The treatments that are available have little biological rationale. They have uncertain effectivity. They are not evidence-based, and many times it's the patient who wants it. When you look at the medical treatments, we'll go through them. Hormonal manipulations, the vasoactive measures, the L-arginine, the sildenafil, the pentoxifillin, the vitamin E, you don't even need to remember them. There are so many of them in the market. There are interventional methods as well, the endometrial scratch test, the use of stem cells, hysteroscopic adhesiolysis, and the infusion of growth factors like GM-CSF. So let's look at the first one, hormonal manipulations with estrogen. The estrogens that can be given to improve the endometrium may be oral, may be vaginal, may be intramuscular, but most of the cases we give it orally. Since God has given one more area for insertion, that is the vagina, it is used as well, and it gives you the highest amount of estrogen in the blood when you measure patients who take vaginal estrogen, and this is clear. We use the transdermal as well. The transdermal gives us the most consistent values of estradiol. We use the vaginal, if oral administration is not producing a good endometrial echo, then we use vaginally or we use transdermally. Transdermal is not available, so we have to resort to a vaginal estrogen sometimes. Is aspirin useful? The evidence says that there is no use of aspirin to improve the endometrium, but we use it all the time. L-arginine and sildenafil. The concepts of using this is basically that it relaxes the arterial and the venous smooth muscle, inhibits platelet agglutination, and hence improves the vascularity. Because we saw that one of the problems with thin endometrium is a vascular problem. Sildenafil, what does it do? It improves the arterial blood flow. It decreases NK cell activity. It improves the implantation and the deserialization by affecting the beta integrins and the VEGF expressions. How do you use it? It increases the implantation rate, it increases the ongoing pregnancy rate. This was a study by Sher et al. They use it vaginally 25 milligrams 3 times to 4 times in a day. So the woman is inserting a tablet in the vagina virtually all the time. Does it work? Evidence says that it works. I don't know. I don't know whether it really works. Using pentoxifilin. Pentoxifilin is used in a dose of 800 milligrams along with 1000 IU of vitamin E for a period of 6 months, and this is particularly useful in patients who have had, who are cancer survivors. And we use this quite often, and we have got several pregnancies from this regimen. This was first published by Friedman, and we found it very useful in our own practice. Anything else can be tried? The time-old using of tamoxifen and letrozole. Of course, letrozole is not available, but they use tamoxifen in FET cycle to improve the endometrium. Endometrial scratch test, intentional endometrial injury. It has been found that when it is done in the luteal phase of the previous cycle, it actually increases pregnancy rate. And so much so that this particular article had mentioned that local endometrial injury in the cycle preceding the stimulation gives you a pregnancy rate of, increases the pregnancy rate by 70%. When do you do it? From where do you do it? We usually do an endometrial scratch test on the posterior wall, 1 millimeter, just a little part of the endometrium is scraped off, and this is done on day 21 of the previous cycle, but you must be absolutely sure that the patient is not pregnant. Can you do a hysteroscopy as well? Yes, it has been shown that either an endometrial scratch or a pre-IVF hysteroscopy actually increases pregnancy rate. The biological the explanation for this is probably by doing a hysteroscopy, you are identifying and correcting some lesions in the uterus. Probably you are allowing for cervical dilatation, and so you really know where to put your embryos back. You're also doing the same as endometrial injury and probably improving implantation. How does this work? God knows. This was done age immemorial. As I still remember the older women, the mother-in-laws come and say, do a DNC and she'll conceive. We never respected their thoughts at that time, but today we give it a cytokine implantation turn to it. What does endometrial injury do? It releases cytokines, histamines, desterilization, and increases receptivity. Same thing that everything does. Increasing the expression of genes related to endometrial receptivity in a spontaneous manner, and there is a 2 to 10-fold increase in the genes. And the next, can you do hysteroscopic adhesiolysis for patients with Asherman, with a hysterosalpingogram picture like this, a 3D like this? You can do adhesiolysis, but does it really help? There are data to show that the pregnancy rates increase, but there is also data to show that the abortion rates, the placental adhesions increase, and they have been found to have placenta accreta as well. We've had 2 patients of placenta accreta after this. Persistent thin endometrium and hydrosalpinges. We know that once you take the tube off, like the one you had just shown, Dr. Jayakrishnan, it increases the pregnancy rate, and this is level 1 evidence. Intrauterine infusion with GCSF, we have started to use it. We found it extremely useful. We still haven't put our data together, but how do we use it? In an IVF cycle, we know that the patient has a poor endometrium. Then we look at the endometrium on the day of HCG. If on the day of HCG it is less than 7 millimeters, we instill the GM-CSF, and that is 300 micrograms, and just like an IUI, and repeat it 2 days later if the thickness hasn't improved. Have we got our results? We are in the preliminary phase. We are doing it. We find it very helpful. We've got many patients pregnant, but I don't know whether they would have got pregnant either way. This came from this case report on the use of GM-CSF. And and Norbert Gleicher was the first person who started to work on it, and there are several studies now from him speaking about the use of GM-CSF. The application in regenerative medicine, the use of stem cells. Of course, we know that the adult autologous stem cells from the patient's own bone marrow is taken. Endometrial angiogenic stem cells are separated by immunomagnetic isolation. These cells are then put back into the endometrial cavity, and they claim, this was Sonal Panchal from Gujarat, she claims an increase in her pregnancies, and we tried it on a couple of patients who were cancer survivors, and we didn't find it very useful. The basis is that recent evidence has implicated that bone marrow derived cells have endometrial progenitors, and these progenitors and these cells are responsible for improving the endometrial echo once the patient has gone through this treatment. So what is, in the last 3 minutes, I'll just put everything together. What is our approach in managing a thin endometrium? The most important is take a detailed history, pay attention to the lining, the morphology, and the volume of the endometrium and its vascularity. Investigate according to an agreed clinic protocol, which we follow in our lab. We have standard operating procedures for this as well. We rule out pathology. Then we look at our stimulation protocols and try to change something from the previous cycle, and then consider adjuvants on a case-to-case basis. This is how we handle a thin endometrium. In an ART cycle, we assess the embryos. We always do a pre-IVF hysteroscopy, and versus a scratch if a hysteroscopy is already done. Believe me, it helps. We reduce our dose of stimulation in the next cycle. We suppress adrenal androgens in patients with PCOS with dexamethasone. We also suppress the ovarian function in some cases with Ocipil. If the endometrium is too thin, we administer estradiol patch. And in patients with PCOS, we use more of we add a little LH if the endometrium is poor. Despite this, if the endometrium is poor, we freeze all embryos, we transfer in a frozen embryo thaw cycle, and thereby the patient is benefited because she doesn't have a risk of hyperstimulation syndrome, and also the embryos implant in a more physiological environment, and babies are free of the impact of ovarian stimulation and on development. Then what is the ultimate answer if nothing works? How do you solve the problem? Of course, there's money. You can change the person behind the uterus, that is surrogacy, or you can change the uterus inside the patient, that's uterine transplantation. But I find my personal recommendation to this Dr. Jayakrishna is the Serenity Prayer. It is useful for both doctor and patient. God, grant me the serenity to accept things I cannot change, the thin endometrium, the courage to change things I can with hysteroscopy, endometrial stab scratch test, and of course GM-CSF, and the wisdom to know the difference. I have learned the art of medicine consists of amusing the patient while nature cures the disease. Thank you very much for your patient listening.